Good afternoon. Today my topic is long-term result of adjustable frontalis suspension surgery for various types of ptosis. Surgical management of ptosis still remains a challenge even for the expert oculoplastic surgeons. Accurate prediction of eyelid height from frontalis suspension surgery is difficult to assess at the end of surgery. Even after all calculations, undercorrection or overcorrection is quite common. Reasons for not achieving desired effects are effect of local and general anesthesia, patient lying in supine position, lid swelling, anxiety of patient in operation theatre. To describe, the aim was to describe and evaluate the long-term results of the technique, Chandra's adjustable frontalis suspension technique that corrects ptosis on first post-operative day, ensuring desired lid margin height. It was a retrospective study. A total of 182 eyes were operated, and out of them 160 eyes who have followed up of minimum 1 year were taken in this study. The study was performed in the Department of Ophthalmology, Banaras Hindu University and Chandra Eye Care, Varanasi between July 2007 and June 2022. The cases included were congenital ptosis, blepharophimosis syndrome, traumatic ptosis, third nerve palsy, ptosis in myasthenia gravis, chronic progressive external ophthalmoplegia, Marcus gun jaw winking phenomena, aponeurotic ptosis, acquired ptosis after tumor resection. A routine frontalis suspension sling surgery was performed using silicone rod by Fox pentagon method under local anesthesia. A needle was passed from the superior incision in the anti-clockwise direction through the brow and the tarsal incisions and came out through the superior incision again. The ends of silicone rod at the apex incision were passed to the Watzke's sleeve provided with orosling in a crisscross pattern. The needle thus coming out from the temporal brow incision after passing through the Watzke sleeve now lies nasally, and the other needle through the nasal brow incision lies temporally. The end of the first emerging needle was then again passed subcutaneously deep through the initial pass such that the needle came out through the nasal brow opening. Similarly, the other needle was passed subcutaneously to emerge through the temporal brow incision. So these are the images. Now it was seen that as the silicon rod was pulled, the lid got elevated. No attempt was made to elevate the lid on table. All the three superior incisions were sutured. Frost suture to the lower lid was not given as the eyelids were not raised on the table. The eye was patched. On first post-operative day, the ends of silicone rod were pulled gently. As the end were pulled, the upper lid got elevated. The silicone rods were pulled and trimmed closely to brow incision when the lid margin was approximately 2 mm from the upper limbus, or same as the other eye if the other eye was not ptotic. The ends of the silicone rod retracted and went deep in the wound. So these results were at the end of 1 year after surgery, desired lid height was achieved in 152 of 160 eyes. Till the completion of the study, 136 eyes achieved good elevation and did not require any further surgery. Resurgery was required in 16 patients, 1 month to about 10 years follow-up. 8 patients had mild ptosis, but they did not give their consent for any further surgery. So the majority, like 12.5%, were undercorrected, that is 20 number of eyes. Advantages are adjustment done without the effect of LA or GA, without any lid swelling, in sitting position with both eye open, in consultant's chamber, can be adjusted at later date, 1 week to 10 years. Temporal and nasal lifting can also be done. Adjustable frontalis suspension surgery is an effective method in the management of congenital and acquired ptosis. The cosmesis obtained is much more superior as compared to the conventional zinc surgery. Thank you.
Thank you, doctor. Are you a part of the study? Because your name isn't anywhere on the list.
I'm in the first year resident.
Okay, so we've allowed you to present, but then it will not be considered as competitive because you're not even one of the co-authors. Yeah, it's an interesting study. I wish the main author was here. You did not even tighten on the table. Everything was okay, just to see it, or you don't know?
Post-op, when the patient came in the OPD.
No, I'm saying intra-op. Intra-op, we usually tighten it once to see have we got everything okay.
In this procedure, intra-op, we don't pull the string, but...
No, I've understood that. But when we pass it, normally during surgery, we just check the contour once. So they were so confident they didn't even need to check the contour. Good. All right.
Okay, thank you, doctor. Thank you.